Just see if he's paying attention. Okay, I'm going to be doing the diabetes lecture. I'm going to be doing part 1, part 2, and part 3. Part 1 is short and sweet. Part 2 is pretty neat. And part 3 is pretty deep. That pretty much sums it up. So if you haven't gotten your book out, if you would, get your Med-Surg book out. We're going to be covering chapters 45 and 47. 45 is just a little bit of review of the A and P of the endocrine system, mainly concentrating diabetes, chapter 47. Also, just a little bit out of your PEDS book, chapter 29, pages 992 through 1006. All right, so I'm going to get myself off of here. And let's pull a PowerPoint. All right, we're going to be talking about diabetes, part 1. And you can see that I've got someone coming out, going into the restroom. So that's kind of what we think about. Someone urinating quite a bit as being one of the signs and symptoms. So again, for your readings, Med-Surg book, chapters 45 and 47. Perform PEDS, I'm not sure what that means, but PEDS book, chapter 29, pages 992 through 1006. Hint, theorist anyone? So study your theorist. Pharmacology for sure. Delegation and lots of it. Levels of prevention, always. That would be your primary, secondary, and tertiary. And Tanners, oh yes. If I do not repeat some of this stuff, you will forget it. I'm a firm believer in repetition is the mother of all learning. So let's look at the A and P of the pancreas just a little bit. When I think about the endocrine system, I think about the 3 S's. It does 3 things. It synthesizes, it stores, and secretes. Okay? So we've got these glands and glandular tissues that either synthesize, store, or secrete chemical messengers or hormones. And then these hormones will travel through the blood to a certain target cell. The pancreas we know is triangular. It's behind the stomach, anterior to L1 and L2. Really, if you think about the pancreas, it is very powerful. Can do a lot of things for no bigger than it is. Only about 6 inches long and 1 to 2 inches wide. So the pancreas, not to be very big, has some powerful hormones. It weighs only about 60 to 90 grams, and one of the unique things is that it has endocrine as well as exocrine functions, and we'll talk about the difference in that. We start secreting insulin at a very early age, actually at about 20 weeks gestation. Now, there are 2 types of functions, we just said, of the pancreas. The first type is exocrine, and that means that this is a gland that secretes substances directly onto an organ or surface or into a duct. Pancreatic enzymes are secreted via duct to the duodenum, for example. So, in other words, if it's an exocrine function, it has to go through a duct. There has to be some kind of duct system. Compared to endocrine system, it's a gland that secretes substance directly into the blood. Then it will travel to where it needs to go. For example, the beta cells secrete insulin into the bloodstream, and then therefore that helps lower the blood sugar. So, if we're thinking about what's the main difference then between the endocrine and the exocrine function, it is one has a duct and one is ductless. So, the duct system is the exocrine function. The endocrine function is ductless, and that's the main difference. They both are secreting hormones. They're both going to do a job. They're just going to go about it a little bit different. So, some food for thought. We're going to be focusing on the dysfunction of the endocrine instead of exocrine gland. And when can these disorders occur? Well, if you think back a couple of slides ago, we said as early as 20 weeks gestation, we're already secreting insulin. So at any age, including the fetal and neonatal periods, at any age. So let's look at the islet cells. There are 3 distinct types. And we start life with about 1 million until we start doing things that destroy them. The first type is called the A alpha cells. And what do we know they do? They secrete glucagon. B, beta cells secrete insulin. And D, delta cells secrete somatostatin. And those are the three that we're going to be concentrating on and talking about. So let's look at first the functions of glucagon that is secreted by the A, alpha cells. We know this is a hormone that has actions that is opposite those of insulin. So glucagon's on one end of the extreme, insulin's on the other. So if insulin decreases glucose, glucagon must increase glucose levels. And it does that in the form of glycogen. Now we're going to be talking about a lot of G words, as I like to call them. So make sure we get all these G words down pat. Where does glycogen come from? The stored cells. Whenever blood glucose levels are low, they put out the glycogen, and so that it raises the glucose levels back up. Now, glucagon is called a counter-regulatory hormone, and it's called that because it again has actions opposite that of insulin. So there are other counter-regulatory hormones that you need to be aware of as well. The other counter-regulatory hormones include epinephrine, norepinephrine, growth hormone, and cortisol. So the counter-regulatory hormones are glucagon, epinephrine, norepinephrine, growth hormone, and cortisol. So all of those have the opposite effect of insulin. Instead of lowering the glucose levels, all the counter-regulatory hormones increase the glucose levels. So let's talk about some G words. First, we need to memorize the difference in gluconeogenesis, which is the formation of glucose from non-carbohydrate sources, such as fats and proteins. So if we don't have glucose to fuel the cells, then we turn to non-carbohydrate sources such as our fats and proteins. This would be long term. This would be something we would do short term. Now, glycogenolysis is the release and conversion of stored glycogen into glucose from the liver and muscle cells. This is what we do for short-term needs. So someone needs to have their glucose increased. Let's say they've gotten too much insulin. The body's going to help. What's it going to do first? It's going to go to these short-term needs. So it's going to convert. It's going to go to the glycogenolysis. It's going to go to those stored cells where glucose has been stored in the form of glycogen, and it's going to convert it back into glucose and spit it back into the bloodstream to help get the glucose level up. After a while, if you use all those stored sites from the liver and muscle cells, then you're going to have to go to your long-term needs, and you're going to have to start using non-carbohydrate sources such as fats and proteins. So that's where we get in to this. So when would glucagon be released? Well, anytime we need to protect the body from hypoglycemia. Anytime we need to protect the body from hypoglycemia. So here it is in picture form for those of you who are picture kind of people. You have glucagon, which we know is a hormone whose action is to increase blood sugar levels. We just said that. Well, if we need to increase our blood sugar levels, we first go to our short-term needs in the form of glycogenolysis, which stimulates the release and conversion of glycogen back into glucose from the liver and muscle cells, and therefore increases our blood sugar. After a while, we may have to go to our long-term needs, which is gluconeogenesis, which is the formation of glucose from non-carbohydrate sources such as fats and proteins. Now, when we break down fats and proteins, that's lipolysis and proteolysis. In other words, the breakdown of proteins, the breakdown of fats. When we do that, we throw off amino acids, we throw off ketones, we throw off acids. So we have to watch for someone going into acidosis because we've got extra acids in the blood now. All right, so that was the function of glucagon. What's the function of insulin? Well, that's not just to decrease glucose levels. It does other things. It also is the primary regulator of carbohydrate, fat, and protein metabolism. It facilitates glucose transport across the membranes. It is the only hormone that directly lowers blood glucose levels. All the other ones do it indirectly. It augments the transport of potassium into cells. That's a big one you need to remember. It augments the transport of potassium into cells. It stimulates protein synthesis, and it has a basal rate that's continuously released into the bloodstream in small pulsative increments. So about every 10 minutes, bing, you're going to have a little release of insulin. Bing, that's our basal rate. And that basal rate about every 10 minutes is just putting out a small pulsative increment to keep the level normal. Now, what happens if it puts out too much and that glucose level starts going down? Well, we have counter-regulatory hormones in the blood that's going to do what? They're going to kick in, and they're going to try to raise that back up. So they're balancing each other constantly, the insulin and the counter-regulatory hormones. So I have two questions then. Number one, what happens after a meal is eating? Well, if you think about it, after a meal, insulin secretion has to increase, right? Because you've probably taken in some carbs, so insulin increases. That moves glucose from the blood into the muscle, the liver, the fat cells, and stores it in the form of glycogen, so that blood sugar levels decrease and facilitates a stable normal range of glucose. So after a meal, insulin secretion increases, okay? What happens then between meals and overnight? Well, they've got the buddy system. Insulin and glucagon are going to have to work together to maintain a constant level of glucose between meals and overnight. Blood sugar level starts going up, insulin puts out a little bit more. Blood sugar levels start going down, counter-regulatory hormones kick in, glucagon, epinephrine, norepinephrine, all those start kicking in, growth hormone, cortisol. Just an FYI, the average amount of insulin secreted daily by an adult is about 40 to 50 units. So not taking any insulin in, your normal body rate puts out about 40 to 50 units. Now, if you're heavier, it puts out more, about 0.5 units per kilogram of body weight. What effect does insulin have then on the central nervous system? Well, the central nervous system is freely permeable, we know, to glucose. In other words, it does not have to have insulin to transport glucose into those cells. Hyperglycemia will not damage brain cells, but, cells can't survive with a glucose deficiency. That's a powerful statement. What did I just tell you? What was the significance and importance of that statement? The significance and importance of that statement was you always are more concerned about someone who's having hypoglycemia than someone who's having hyper. Yes, hyper's bad, can cause a lot of long-term damage and some other things, and can go into ketoacidosis or HHNK if you or HHNS now if you are type 2. But that statement, hyperglycemia does not damage brain cells, but cells can't survive with a glucose deficiency. The central nervous system stores only a minimal amount of glycogen. It's not like the liver and the muscle cells and all those. So with that said, with that in mind, which one of the following clients would you see first? Mr. Smith, a blood sugar of 50, Mr. Jones, a blood sugar of 80, Mr. Tom, a blood sugar of 160, or Mr. Carter, a blood sugar of 300. And you should have picked Mr. Smith, blood sugar of 50, because of the statement we just made. Functions of somatostatin. It's secreted by the delta cells, we said, and we know that it's released in response to both hyper and hypoglycemia. So it kind of tries to help out insulin and glucagon. It is theorized that somatostatin allows for the influx of glucose into cells after a meal, so it kind of helps with that postprandial hyperglycemia that can occur. So those are the three main islet cells and the functions of those, and you'll need to remember those for test purposes. So let's talk just a little bit more about assessment. Assessment's very important. It's paying attention to the details when someone's talking to you, getting a good history in that subjective data. First thing you're going to do is gather biographical data. Why is that important? Why would you want to know about someone's age, their height, their weight, their gender? Well, all of those are factors that can affect when diabetes starts occurring, what type of diabetes you may have. Uh, Females are more at risk for type 2, we know. So there are reasons that we need those data. Also, your age. At a certain age, type 2 is more likely to occur. With type 1, at certain ages, it's more likely to occur. You always want to know about the chief complaint. Why did they come in? And this can range from very specific details to non-specific. Appetite changes, weight changes, increase in thirst, getting up during the night, increase in urination. You want to know about the past medical history. Do they have a family history? What kind of illnesses have they had? What kind of risk factors do they have? What type of medications are they on? Then you want to know about the psychosocial history and their lifestyle, stress, coping, support. We know all those things. If you don't have those and you're increased stress, that increases cortisol levels. Well, we already know what increased cortisol levels do. They're a counter-regulatory hormone, cortisol, so therefore it increases glucose levels. So if you've got a diabetic who's stressed out, their blood sugar levels are going to tend to be higher because of the cortisol. Lifestyle habits, beliefs, and value patterns. You want to know everything you can about this person, not just the biographical data. We know that hormones affect every body tissue and system, and they're going to cause then a great diversity in signs and symptoms that you're going to see in the endocrine dysfunction. So assessment of the endocrine system is very difficult, and it's going to require very keen clinical skills to detect manifestations of disorders as we're going along. Just an FYI, this isn't in your book, but just some common medications that lower glucose levels and some common medications that raise glucose levels that you may not be familiar with. Glucose lowering, Tylenol, beta blockers, of course you think of insulin, and even your tricyclic antidepressants. But a lot of us don't think about Tylenol being a good glucose lowering agent. Glucose raising, caffeine, barbiturates, birth control pills, corticosteroids. Corticosteroids are a big one, especially with diabetes. That's when we have to monitor their sugars very carefully if they're on cortisol. Now, once they go off of that and taper off of it, the sugars should come back down. Lasix, lithium, and epi. Okay. All right, so a good history, objective data. Well, that involves our physical exam. We're mainly going to be doing inspection, palpation, and percussion. Inspection and palpation. We cannot percuss these endocrine organs. So inspection. We're going to do a general head-to-toe assessment. We're going to be looking particularly at their skin. Diabetics tend to have very dry skin. We're looking at their feet, because they usually have a lot of problems with their feet. Need to always check their vision and encourage them to get eye checkups. Palpation, we're going to be palpating to make sure for nodules, masses. And then, of course, percussion and auscultation are not normally part of the endocrine system because they are internal organs. All right, that is the end of part 1 that covers the A&P and assessment. If you have any questions or concerns, you can speak now or forever hold your peace. All right, if you're daydreaming, texting, catnapping, it's time to wake up on me. I would encourage you to read pages 1363 through 64 that covers a little bit of physical assessment and how it affects each one of those organ systems in Chapter 45. All right, so in preparing us for our second adventure that we're fixing to go on, let's look at type 1 versus type 2. In type 1, usually it occurs in the young, less than 30, with a peak age of 10 to 15. Usually in the young, less than 30, peak age 10 to 15. As compared to type 2, usually over 30, with a peak age in your 50s. Big difference. This one, type 1, comes on very abruptly. All of a sudden, you'll have the increased thirst, the increased urination, the increased hunger. Here it's very insidious. It comes on slow, a very slow onset with type 2. It may take years to develop into full type 2 diabetes. With type 1, it is involved with certain HLA typing. And HLA typing has to do with marking a cell as self. When someone gets ready, for example, to be some type of donor, let's say they're an organ donor, they have to match up their HLAs, or if they don't, the body will see that as foreign and will reject it. That's where we get into all the organ rejections because of the HLAs not matching up. So people with certain types of HLAs are more prone to type 1 if they have those, and we'll talk about what those are here in a little bit. And usually it is brought on by some type of a virus affecting those HLA types. With type 2, there's no relation to HLAs. With type 1, you have antibodies who are positive, so we think it is an autoimmune. For some reason, the virus attacks the body. It turns on itself. It kills the beta cells in the pancreas, and we have autoantibodies that pop up. With type 2, there are no autoantibodies. With type 1, usually there's no insulin. It's complete destruction of the beta cells. The beta cells are wiped out. They can no longer do their thing. They cannot secrete insulin, so we have to have insulin from a different source. With type 2, usually there's insulin resistance, but you do have some insulin on board. With type 1, we think of someone who's very thin. With type 2, we think of someone who's very obese. With type 1, we think of the 3 Ps, which we talked about earlier. The increase in thirst, urination and hunger, and fatigue. Now with type 2, we may or may not see the 3 Ps, but we're going to see fatigue and some other signs and symptoms that we'll talk about later, like slow wound healing. With type 1, they're prone to ketosis. Why are they prone to ketosis? They have no insulin. If they don't have any insulin, remember, then they start storing all that glucose and building it up, and the glucose level is messed up. Then they may go into ketoacidosis, and that's when they start throwing off using the fats and the proteins. And we talked about that earlier. That's when you get into the long term, someone that's gone into DKA. With over here, usually with type 2, they're resistant to ketosis. They don't go into full-blown metabolic acidosis, and that's because they have some insulin on board. With type 1, usually how you're going to control that with insulin, diet, and exercise. With type 2, it's exercise, meds, and may or may not be insulin. We actually have some type 2s who are converting over and happen to be on insulin now. With type 1, it affects males and females equally, but with type 2, it's greater in females. I guess they're trying to say we're more obese ladies. All right, so here's some for you visual folks. Type 1, the increase in the 3 Ps, polyuria, increased urination. Polydipsia, increased thirst. Polyphagia, increased hunger. Weight loss, fatigue, increased frequency of infection, rapid onset, insulin dependent, the familial tendency, and that familial tendency is HLA typing, which we'll talk about a little bit. So here when it's saying familial tendency, it's talking about the HLA typing. Because you'll see a lot of people come out with type 1, their children, they'll say, well, no one in our family's had, this can't be diabetes, this can't be. It is not hereditary, type 1 primarily. It has to do with the HLA typing and the presence of viruses turning on the body. Peak incidence, again, was 10 to 15 years of age. Ah! I did not give anyone permission to use my picture. I'm just kidding. But I do have this prototype. I am myself a type 2 diabetic. Sedentary lifestyle, which I don't have. Familial tendency, type 2 diabetes runs in my family very heavily. It starts about an average age of 50. You'll have a history of hypertension usually, fatigue, decreased energy, obese. That's our biggest risk factor for type 2. Reoccurring infections. You may or may not have your 3 Ps. And blood sugar levels stay above usually 126 milligrams per deciliter. As you can see, she is the prototype for type 2. Sedentary lifestyle, she's got some foot issues, poor wound healing, she's chomping on her chocolates, she's got her antihypertensive and antibiotics ready to go. Delegation will be on the exam, I said, so when we think about the CNA, I want you to think about things they can reinforce. They can reinforce education like I knows in teaching, but they are not to initiate it. Stick to the basic skills a CNA can perform when you're taking an exam. Can they consult someone? No. LPN, they can reinforce again education, discharge teaching. They have observational skills, not assessment skills. That means when they observe something and they observe that something's wrong, they should report that to the primary RN who goes in and further assesses that. IV meds. Well, IV meds not in every state. And because of that, you won't see it on boards a lot for the PN boards. You will on the RN boards because IV meds are not a required assessment for every LPN in every state. So stick to your basics of when you think what LPN can do. Observational skills, medications, dressing changes. Okay. Your Arkansas State Board of Nursing will actually tell you that if you have a med that requires further assessment after you give it, then really the RN should be the one giving it. For example, narcotics. All right, even though I know we practice some things different depending upon where you work and how you have been trained. All right, that's the end of this section. I want you to call me if you have any questions or any concerns, and I think we're going to have lots of fun on our adventure. Again, that one was the short and sweet version. Thank you.